Hi, my name is Joe Muscolino. Welcome to the companion video for the Muscle and Bone Palpation Manual. This companion video will demonstrate the muscle palpations that are described and shown in the text. The palpations in this video will follow the same order of presentation as in the book. The trapezius begins at the external occipital protuberance of the superior nuchal line, runs down the spine to the spinous process of T12, runs up to the root of the spine of the scapula and attaches along the spine of the scapula, the acromion process, and the lateral clavicle, and from there it returns to the superior nuchal line of the occiput. The trapezius is an upward rotator of the scapula, so to engage it we abduct the arm at the shoulder joint, which requires upward rotation of the scapula, and we then add resistance to that action and ask the client to slightly retract the scapula. We can see here the lateral border of the lower trapezius popping and being palpated. We strum perpendicularly against it. As the client alternately contracts and relaxes the trapezius, we continue palpating from the lower trapezius up into the fibers of the middle trapezius here, and we continue strumming perpendicularly across it toward the upper trapezius. As we get into the upper trapezius more, to better engage it, we ask the client to elevate the head and neck at the spinal joints, and we can see it pop out visually, and we can then strum it even better. We can then palpate it all the way to its lateral clavicle attachment there. So the trapezius attaches from the lateral clavicle up to the superior nuchal line, down the spine, and back over to the scapula. The rhomboids attach from the medial border of the scapula to the spinous processes of T5 to C7. The rhomboids retract the scapula at the scapulocostal joint, but so does the trapezius which overlies it. To better palpate the rhomboids, we inhibit the trapezius. We do this by placing the client's hand in the small of his back. This requires extension and adduction of the arm at the shoulder joint, which requires downward rotation of the scapula at the scapulocostal joint, which then reciprocally inhibits any upward rotator of the scapula, which the upper trapezius is. When the rhomboids engage, we can often see the inferior border. We then place our palpating fingers on the belly of the rhomboids, and we perpendicularly strum it as the client contracts and relaxes the rhomboids by retracting the scapula at the scapulocostal joint. We now palpate the entirety of the rhomboids by following this protocol. The word rhomboid literally means diamond shape. So if we find the inferior border here, then we know the superior border will be parallel, and we can follow it up to its attachment on the spinous process of C7 here. So we can trace the outline of both rhomboid muscles like this. To palpate the levator scapulae, we first outline the medial border of the scapula from inferior angle to superior angle. The levator scapulae attaches along the medial border up to the superior angle. From there, the levator scapulae travels superiorly to attach to the transverse process of C1, the atlas, which is located much more anteriorly than most people realize. The muscle then runs along this line. Because the levator scapulae is deep to the upper trapezius, and the upper trapezius is also an elevator of the scapula, we want to relax the upper trapezius so we can palpate the levator scapulae through it. We can accomplish this by placing the client's hand in the small of his back. Placing the client's hand in the small of the back requires extension and adduction of the client's arm at the shoulder joint. This requires his scapula to downwardly rotate. Therefore, by the neurologic reflex of reciprocal inhibition, all upward rotators are inhibited from contracting. The upper trapezius is an upward rotator, so it is inhibited and relaxed, and we can better palpate the levator scapulae through it. We now ask the client to perform a very slight elevation of the scapula at the scapulocostal joint and feel for the contraction of the levator scapulae by strumming across it. It is important that the contraction is very gentle and small, otherwise the reflex of reciprocal inhibition will be overridden and the upper trapezius will contract anyway. We continue to palpate the levator scapulae superiorly as the client alternately contracts and relaxes the muscle. Once we are no longer palpating the portion of the levator scapulae that is deep to the upper trapezius, in other words, once we are on the levator scapulae in the posterior triangle of the neck, we do not need to have the client keep his hand in the small of the back. The posterior triangle of the neck is bordered by the upper trapezius posteriorly, the sternocleidomastoid anteriorly, the occiput superiorly, and the clavicle inferiorly. We can now remove the client's hand from the small of the back, and we can now ask the client to try to elevate the scapula with more force against our resistance as seen here. And we now strum perpendicularly across the levator scapulae in the posterior triangle of the neck, following it superiorly toward its attachment on the atlas. Here is the outline of the levator scapulae from the scapula to the atlas. To palpate the levator scapulae seated, we first outline the scapula. Here is the medial border, the spine of the scapula, the root of the spine, and the superior angle. The attachment of levator scapulae on the scapula is here, and it goes up to transverse processes of the cervical spine 1 through 4 here. This is the course of the muscle. Where the levator scapulae is deep to the upper trapezius, we place the client's hand in the small of the back. This causes extension and adduction of the arm at the shoulder joint, which then causes downward rotation of the scapula at the scapulocostal joint, which inhibits the upper trapezius because it's an upward rotator of the scapula. We now ask the client to do a gentle and small elevation of the scapula, and we strum perpendicularly across the levator scapulae. We then follow the levator scapulae toward its superior attachment in baby steps as the client alternately contracts and relaxes the muscle. Once we are palpating the levator scapulae beyond the border of the upper trapezius we see here, we no longer need to have the client's hand in the small of her back, and we can now have the client elevate the scapula with more force against our resistance as we strum perpendicularly across the levator scapulae in the posterior triangle of the neck. At its most superior end, the levator scapulae goes deep to the sternocleidomastoid. The posterior deltoid is located here. To better locate it, we first find the spine of the scapula by strumming up and down across it. Once the spine's found, we can better locate the borders of the posterior deltoid. Finding the spine of the scapula, we drop inferiorly off its lateral end, and when the client horizontally extends the arm against resistance, we can strum across the belly of the muscle. We continue palpating the belly of the muscle distally toward its distal attachment on the humerus. Here is the outline of the posterior deltoid. To palpate the posterior deltoid with the client seated, we raise the client's arm to 90 degrees of abduction, locate the spine of the scapula by strumming across it. We then drop inferiorly from the lateral end of the spine of the scapula and ask the client to attempt to horizontally extend his arm against our resistance. This causes the posterior deltoid to engage, and we can palpate its contraction by strumming across it. We then follow the posterior deltoid from its proximal end toward its distal end as the client alternately contracts and relaxes the muscle. The anterior deltoid attaches from the lateral 1/3 of the clavicle and runs down to the deltoid tuberosity here. To engage the anterior deltoid, we ask the client to try to move her arm at the shoulder joint obliquely into flexion and abduction. It is often helpful to show her as we have just done. When she then contracts against our resistance, we can strum across the muscle perpendicularly. We begin palpating the anterior deltoid proximally and continue palpating it distally as she alternately contracts and relaxes the muscle until we get to the deltoid tuberosity attachment here. The anterior deltoid is located here. It attaches from the lateral 1/3 of the clavicle and runs distally to attach to the deltoid tuberosity here. To engage the anterior deltoid, we bring the client's arm up to 90 degrees of abduction and ask the client to try to horizontally flex the arm against our resistance. We see the muscle contract here. We then strum perpendicularly across it and palpate the entirety of the anterior deltoid from proximal attachment to distal attachment. The pectoralis major has two heads. The clavicular head is located here, and the sternocostal head is located approximately here, from the sternum and upper 7 costal cartilages. Both heads attach distally onto the lateral lip of the bicipital groove of the humerus here. To palpate and engage the sternocostal head, we resist the client from adducting her arm at the shoulder joint and feel for the contraction of its fibers. We can also palpate it into the anterior axillary fold of tissue as seen here and feel it all the way to the lateral lip of the bicipital groove of the humerus here. To palpate and engage the clavicular head, we ask the client to move her arm obliquely into a combination of flexion and adduction, and we resist this motion. This engages the clavicular head, and we can strum across it perpendicularly. So the clavicular head attaches from the medial clavicle to the humerus, and the sternocostal head attaches from the sternum and costal cartilages to the humerus, and the pectoralis major creates the anterior axillary fold of tissue that you see being palpated here. Pectoralis minor goes from the coracoid process of the scapula down to ribs 3, 4, and 5. To palpate this, the first thing we need to do is find the coracoid process. So I first locate the clavicle, and then I find the concavity of the clavicle, which is on its lateral end. I drop down from there, and there is the coracoid process right there. So the position I'll need you in to do this palpation is I'll ask you to take your hand, put it in the small of your back. By putting the hand in the small of your back, it extends and adducts the arm at the shoulder joint, which requires the scapula to downwardly rotate. And then when the scapula downwardly rotates, the pec minor will be engaged to do that downward rotation. So now go ahead and lift your hand away from the small of your back, and that engages the pec minor. And I can strum across the fibers for the pec minor, right here. And I can palpate it from its coracoid process. You can relax. From its coracoid process to ribs 3, 4, and 5. Go ahead and lift away again. And again, I can strum it perpendicular to locate it. To help visualize the serratus anterior and subscapularis muscles, it helps to look at a skeleton. Placed upon this skeleton are two pieces of paper that represent these muscles. This piece here represents the serratus anterior coming from the medial border of the scapula to the upper 9 ribs anterolaterally. This piece here represents the subscapularis coming from the anterior surface of the scapula and going to the humerus. Even though both muscles are located between the rib cage and the anterior surface of the scapula, as we can see when the arm is away from the body, the serratus anterior hugs the rib cage wall, whereas the subscapularis stays over toward the humerus. Here, the finger pads are oriented toward the rib cage wall to palpate the serratus anterior. Subscapularis, serratus anterior, subscapularis, serratus anterior. Many people have a difficult time visualizing the serratus anterior. It attaches from the posterior surface of the entire medial border of the scapula, runs between the scapula and rib cage, and then attaches to the upper 9 ribs anterolaterally here. To palpate this muscle, given that it is a protractor of the scapula, we place the client's arm so it is straight up in the air. Then we ask the client to raise his hand toward the ceiling, which is protraction of the scapula. This engages the muscle so we can palpate it. We can even see the slips of the serratus anterior here. So as the client engages this muscle by pressing up against our resistance, we strum across the serratus anterior, accessing as much of it as possible. To better access the upper fibers, we change the angle of the client's arm, ask the client to press up against us, and then we can palpate the upper fibers here. To better access the lower fibers, we change the angle of the client's arm to be like this, and then as the client presses up against us, we palpate the lower fibers. If we want to better access the portion of the serratus anterior that is deep to the pectoralis major, we can do so by pressing in under the pectoralis major and pressing in against the rib cage attachments as shown. All deep palpations should be done gently but firmly, and we always sink in slowly. To palpate the infraspinatus and teres minor, we begin by outlining the scapula. First we find the medial border, follow it from the inferior angle up to the superior angle. We then locate the spine of the scapula by strumming across it, up and down. To now locate the infraspinatus, we drop below the spine of the scapula into the infraspinous fossa onto the belly of the infraspinatus muscle. We now ask the client to laterally rotate his arm at the shoulder joint against the resistance of our right thigh, and we feel for the engagement of the infraspinatus as the client contracts the muscle. We can then palpate the entire belly of the infraspinatus in the infraspinous fossa in baby steps as the client alternately contracts and relaxes the muscle. We now follow the infraspinatus from proximal on its belly toward its distal attachment on the humerus. As the client engages it, we strum. The client then relaxes. We follow in baby steps distally until we reach the distal attachment on the greater tubercle of the humerus. The infraspinatus attaches in the entire infraspinous fossa of the scapula, and it then attaches distally onto the greater tubercle of the humerus, deep to the posterior deltoid here. To now palpate the teres minor, we have to find the lateral border of the scapula, which is here. We palpate at the superior end of it, and we ask the client again to laterally rotate his arm at the shoulder joint against the resistance of our right thigh. And here is the teres minor popping out here, and we can easily strum across it. Strumming perpendicularly to the muscle, we follow it distally toward its distal attachment on the greater tubercle of the humerus. As the client engages, we feel the contraction, and here is the greater tubercle located directly here. To palpate the teres major, we begin by outlining the scapula. We start in the medial border from inferior to superior angle. We then strum across the spine of the scapula to locate it, and then we locate the lateral border of the scapula, and we place our palpating fingers at its inferior end here. We then ask the client to attempt medial rotation of the arm at the shoulder joint against the resistance of our left thigh, and we feel for the contraction of the teres major. Its contraction can be seen clearly here. We continue to palpate the muscle toward its distal attachment on the arm as the client alternately contracts and relaxes the muscle. Our client here is in very good shape, and the outline of the teres major is very apparent as it goes from the scapula to the medial lip of the bicipital groove of the humerus. We can also palpate the border between the teres major and the latissimus dorsi. Here's the teres major, there is the latissimus dorsi. Seated palpation allows us to take advantage of the fact that the supraspinatus is not only an abductor, but also a flexor of the arm. To palpate it, we first locate the spine of the scapula by strumming perpendicularly. Once we find the spine, we drop superiorly into the supraspinous fossa. We're on the supraspinatus, and we ask the client to flex and abduct the arm at the shoulder joint, an oblique motion. We then continue to palpate the entirety of the supraspinatus as the client alternately contracts and relaxes the muscle. To locate the supraspinatus, it is helpful to first locate landmarks of the scapula, the inferior angle of the scapula, the medial border, the spine of the scapula, and the superior angle. Once we are confident of the location of the spine of the scapula, we drop just off it superiorly into the supraspinous fossa here where the supraspinatus is located. To engage the muscle, we ask the client to gently abduct against our resistance, and we can palpate the contraction of the muscle. It is important that the contraction is gentle, or the overlying upper trapezius might contract to stabilize the scapula, and this would block our palpation of the supraspinatus. We then follow the supraspinatus distally until the acromion process is reached. To then accurately locate the distal tendon of the humerus on the other side of the acromion process, we find the spine of the scapula and draw a line parallel with it until it hits the humerus, and that will be the location for the distal attachment of supraspinatus on the humerus. To then confirm that we are on it, we ask the client to gently contract the muscle, and we can strum across the tendon. Again, the contraction of the supraspinatus must be gentle, or in this case, the overlying deltoid will contract and block our palpation. To help visualize the serratus anterior and subscapularis muscles, it helps to look at a skeleton. Placed upon this skeleton are two pieces of paper that represent these muscles. This piece here represents the serratus anterior coming from the medial border of the scapula to the upper 9 ribs anterolaterally. This piece here represents the subscapularis coming from the anterior surface of the scapula and going to the humerus. Even though both muscles are located between the rib cage and the anterior surface of the scapula, as we can see when the arm is away from the body, the serratus anterior hugs the rib cage wall, whereas the subscapularis stays over toward the humerus. Here, the finger pads are oriented toward the rib cage wall to palpate the serratus anterior. Subscapularis, serratus anterior, subscapularis, serratus anterior. To palpate the subscapularis, we place the client's arm on her trunk and then have her gently hold her elbow with her opposite side hand. We then reach under her body with our non-palpating hand, find the medial border of her scapula, and firmly, passively pull the scapula laterally away from her body wall, This exposes the anterior surface of her scapula for our palpation. We then place the fingers of our palpating hand against the anterior scapula. To engage the subscapularis so that we can feel its contraction, we ask the client to immediately rotate her arm at the shoulder joint. We can even see her elbow lift when she does this. We then feel for the contraction against the anterior surface of the scapula, and we explore and palpate as much of the subscapularis as possible. To follow the subscapularis to its distal tendon on the lesser tubercle of the humerus, we bring the client's arm up and rest it on our left shoulder here for palpation of the right subscapularis. We then passively protract her scapula as before, and then place our palpating fingers on the anterior surface of the scapula. We ask the client to immediately rotate her arm at the shoulder joint to engage the subscapularis, and we feel its contraction. We follow the subscapularis distally in baby steps toward its humeral attachment, strumming perpendicularly across it as the client alternately contracts and relaxes the muscle. When we get to the actual humeral attachment here, we make sure that the client's subscapularis is relaxed so that we can feel the difference between the soft and relaxed tendon and the hard texture of the lesser tubercle of the humerus. The subclavius attaches to the underside of the clavicle, as its name implies, so we first find the clavicle. More specifically, the subclavius attaches from the first rib to approximately this point on the clavicle. To palpate it, we curl our fingers to the underside of the clavicle, and then to engage the muscle, we ask the client to depress the shoulder girdle, and we can strum the contraction of the muscle. We then palpate as much of the muscle as possible as the client alternately contracts and relaxes it.